I will be presenting some information about Jmax in my talk in the next session, particularly addressing that early time point issue. But a question that I'd like to hear from others is, should we be more clinically relevant in these studies designs that if the product is going to be on the skin for only 12 hours or 24 hours, should we then do a surface wash and adjust the sampling schedules for so many before that surface wash and so many after that surface wash to be more representative of the clinical exposure condition?
So I think this is an interesting, and I'm glad you brought that up. So the way I think about this is, if I'm taking ibuprofen or Tylenol or something like that, I may be having it, at 4 to 6 hours, right? And similar to some topical products where it's a 4 to 6 hour dose application. But that doesn't mean that that I only do a 4 to 6 hour PK study, a plasma PK study. And so the intention here is to compare the test and the reference product to understand during the metamorphosis of that test and reference product, across its evaporative metamorphosis, however it's being applied. And the reality is, you take 100 different patients out there and ask them to apply product on their skin, and you will see 100 different ways and 100 different amounts of product that have been applied. So when we talk about that clinical relevance, I think we're really talking about ranges to begin with. And I don't think there's a kind of an exactly right one and an exactly wrong one. The comparison is what really matters. So not, so that's the one part. And most importantly, the comparison of the test to the reference product. And it's okay that we can have a situation where we design the study more for the purpose of being uniquely discriminating to differences between the product. I think those conditions, if you have to choose between that and matching the exact clinical conditions of use, I would encourage, don't worry so much about the exact clinical conditions of use. Choose the conditions for the bioequivalence study that are the most discriminating to pick up any differences between the test and the reference product.
Yeah, and Sam, for us, this is one of those situations where our study design differs when we're looking at innovator products, when we're trying to get as close to the clinical situations. In some situations, we're trying to get disease tissue because we really want to know what's it going to look like in the clinic. And in this situation, the way I see it is you're really trying to show sameness between the test and reference. So some of these little things that we talk about, does it still allow you to discriminate, or whether you're just keeping the conditions the same? So yeah, maybe it's not the ideal situation, but will it impact and give you an answer that shows that they're not sameness without jeopardizing that ability to discriminate?
I think you bring up a good point about the context of use. Yeah, I think that's really fair. For a lot of what the context of this workshop is and what's always present in my mind is that bioequivalence piece of it. But you're absolutely right that in other contexts of use, the underlying principles that are critical for you to preserve may change your judgment on a particular study design.